So guys, if you can hear me, if you can start typing into the chat box or just raise your hand. We'll get started in a few minutes, hopefully. Okay, cool. And also, if you can let us know which country you're from. So if you could just type into the chat box which country you're attending from, that'd be really useful for me and Dr. Sandhu. We'll get started in just a moment. We're still waiting for a few attendees to come in. I can see a couple of names already: Mina, Deepak, Sital, Sarab, Kirthi, Avi, Abdullah, Bahuddin. Welcome all. And I'll just quickly, okay, Abuja, Nigeria, that is Uru Akpa, sorry if I pronounced the name wrong. Shaz from the UK, Kirthi from the UK as well, Waleed. So just give us a moment. We're just going to start live streaming to Facebook at the same time. Surab from Nepal, Mina from the UAE. Dr. Sandhu is just about to join us now. So Vikas, can you hear me okay?
I can indeed, yeah. Can you hear me as well?
Yeah, good, yeah, so I can hear you perfectly. I'm going to start live streaming to the Facebook group, so if you give me a moment.
Yeah.
You may want to start, I'm going to mute my mic if you want to maybe just start. So what the attendees are doing is this, shouting out which country they're from. If you just go through that list perhaps, and I'll start live streaming this to Facebook.
Yeah, absolutely, guys. So fantastic. So we've got Shibuke from Gambia, fantastic. Gökhan from Turkey, Charles from Saudi Arabia. I can see quite a lot of you are starting to join now. We've got 41 participants. Tell us whereabouts in the world you're from, guys. It's always nice to connect with our kind of doctors to see where we're from. Ruki from Sri Lanka, and of course we'll give you a shout out as well. We've got Munaza from Canada, which is fantastic. Mamu from Nigeria, good, fantastic. We've got lots of customers, lots of doctors in Nigeria. Bukola from Nigeria, Sugandia from Sri Lanka, Shafi from India, AV from Kosovo, fantastic. Deepak from Pakistan. Waleed is a Syrian from the Kingdom of Saudi Arabia. Fantastic. People are joining on. 54 participants. Perfect. Good, good, good. Anyone else want to give a shout out? We always enjoy this bit because we get to see whereabouts in the world you guys are. And it's always nice to connect with you, basically, to see where you're from. We've got Mushtaq. You're not taking my name. Oh, where are you from, Mushtaq? Let us know where you're from. We can see where you are. Samaya from India has logged in as well. And Mushtaq has confirmed he's from Pakistan. Fantastic. We've got Rose from East Sussex. So that's not far from us. So, well, it's a couple of hours away. Sumaya from London. Okay, so you're probably about an hour away. Me and Dr. Mo are in Coventry, which is in the Midlands in the UK. So that's a couple of people there that we've spotted from the UK. Innocent from Nigeria. Shaz from Northampton. Well, they're getting closer and closer, Dr. Mo. You're going to get a knock on your door in a minute. So Northampton is very close to us. You're probably about 45 minutes away from us. Nitin is from Canada. Rabia from Stockton-on-Tees, another one from the UK. Mubin Chowdhury from Brighton. Ajibola from Nigeria. Bahuddin, yeah, we know who Bahuddin is. He came through our PLAB 2 Skype session from Afghanistan, but working with the Red Cross from what I remember. And we did a good PLAB 2 session. So I'm sure you're going to be preparing for PLAB 2 now that it's restarted. So that's good to see you here. Mohammed from London. So another UK person. Mohammed Harris from Pakistan. Fantastic. Oh, here we go. We've got someone really close to us now. We've got Anuradha from Birmingham. So Birmingham, if anyone knows where Birmingham is in the UK, is probably about 20 minutes away. It's the second biggest city in the UK. So you've got London, then you've got Birmingham. Birmingham is known as the second city in England. And Birmingham is probably, it's about 20 minutes away. So we're not far at all from you, Anu. So it's good to see you. Good to see people connecting from all over the world.
Vikas, what we'll do then in that case, we'll get started. So this is live streaming to the PLAB2 Facebook group, which is our Inspire Medics group for anybody's wanting to not, if they can't get into the webinar, basically, they can watch it in the PLAB2 group for Inspire Medics. Alabi from Nigeria. Hi, Alabi. Fantastic. Bahudin, yes, still working with Red Cross. Fantastic. So guys, what we'll do is we will get started. Today's learning session is going to only be for an hour, but it's going to be on the latest UK guidelines for hypertension and also for COPD. And this will be very, very important if you are sitting the PLAB 1 or the PLAB 2 exam, or even if you're about to start as a doctor in the UK. It's all going to be relevant. We are going to take questions, and There's a little button at the bottom of Zoom where you can click on the button and you can type in your question, so we know exactly who's asking it. And you can type it anonymously if you want, if you don't want your name present. So I'm just going to give you an outline. I'm just going to start sharing my screen to give you guys an outline of this hour's webinar. So Vikas, give me a thumbs up if you can see my screen.
Yeah.
Okay, cool. So, so it's going to be the latest UK NICE medical guidelines for PLAB 1, PLAB 2, as I mentioned. We'll start off with the COPD guidelines to begin with. That'll be 10 minutes. That'll be the latest guidelines, and these came out in the last 12 months. Then we'll do a Q&A session for COPD, and you can ask questions after that. And then Dr. Sandhu will talk about hypertension for 10 minutes. And then again, we'll do a question and answer session after that. And then finally, we'll do a general question and answer session for PLAB 1, PLAB 2, and jobs, if you are looking for jobs in the UK. I know I think Deepak, Vikas, Dr. Deepak has raised his hand. Deepak, if you've got messages, type it into the box if you don't mind, and we will come to any queries that you have. Shafi's also raised his hand, by the way. So the other thing that we'll do is once we got started, about halfway through the webinar, or about a quarter of the way through, we'll also talk about our PLAB 2 Academy, and we'll also talk about our PLAB 1 mock exam. I think that'd be very important. And if you stay till the end of this webinar, we will offer you some special discounts. These are significant discounts only available in this webinar if you're attending, and they won't last past today. So basically, in about 10 hours time, those special discounts will finish. So please do stay till the end, because it'd be worth getting those discount codes. So let's get started. COPD, which stands for chronic obstructive pulmonary disease. It's a chronic condition, which is what the C stands for, and it's a relatively common condition in the United Kingdom. And a couple of things to be aware of. So this is a diagnosis which also includes emphysema. COPD in the UK includes emphysema as well, and it typically gets diagnosed in smokers over the age of 35, and they tend to have a chronic cough, they tend to have associated wheeze, and they also have recurrent bronchitis infections, usually in the winter months in the UK. So if you're from abroad and you're not used to seasons, for example, if you're from Malaysia or Singapore, in the UK we have 4 seasons. And I know in the tropical countries you have a wet season and a hot season, but we tend to have a winter season, which is in December, January, February. That's when most patients tend to get bronchitis, and also sputum production. So if you have a patient with a cluster of these features, over 35, smoker, chronic cough, wheeze, recurrent bronchitis, sputum production, you should be thinking whether or not this could be a diagnosis of COPD, chronic obstructive pulmonary disease. And if you suspect this, the patient, as well as a range of other investigations, chest x-ray and full blood count, the main investigation to diagnose is a spirometry test. Now, this might come up in the PLAB 1 exam, which investigation is most suitable to diagnose a condition, to diagnose COPD. And if spirometry is one of the options, that's the option you should be selecting for the PLAB 1 exam. If you're sitting the PLAB 2 exam and a patient comes in with suspected COPD symptoms, spirometry is one of the tests you would offer. And usually the nurses do it in the UK, and sometimes the respiratory clinic does it as well. But usually in the UK, it's done by nurses in a primary care setting. So that means in a GP family care clinic. So the diagnostic criteria for spirometry to diagnose COPD is a FEV1 over FVC of less than 0.7. So if you do spirometry and you get an FEV1 over FVC of less than 0.7, you can confidently diagnose COPD, chronic obstructive pulmonary disease. So this is just a recap for everyone. This isn't in the new guidelines. This isn't in the new guidelines. This is existing information you should already be aware of. So let's move on to the next slide, which is again a recap. Now this you don't need to know for the purposes of PLAB 1, so please don't memorize it. For the purposes of PLAB 2, it may be relevant because if a patient comes in and they have severe COPD, that might enable you to manage them better and talk through the management plan in a bit more detail if you think they're going to be severely affected by their condition. But essentially, you don't need to memorize this slide for the exam, but it's good to know. So based on the FEV1, the percentage predicted for that patient, and that's based on age and lung capacity, you can break down the severity into mild, moderate, severe, and very severe. So for example, a FEV1 percentage predicted of over 80% will be classified as mild, whereas one less than 30% will be classified as very severe. Again, you don't need to know this for the exam. It's good to know what classification a patient falls into because it tells you the severity of the disease. Okay, let's now move on to the meat of the actual webinar, the learning points that you need to know. And this is the next slide. So in November 2019, the National Institute of Clinical Excellence, which is the body in the UK which produces national guidelines, updated their guidance on the treatment doses and duration for exacerbations of COPD. So previously, when you had an exacerbation of COPD, so for example, a patient who was getting more breathless, a patient who's producing more sputum, a patient who seemed to have more wheeze-like symptoms in the last couple of days or weeks, you would classify that as an exacerbation. Now, exacerbation can be broken down into two categories: an infective exacerbation and a non-infective exacerbation. So with an infective exacerbation, obviously you would prescribe antibiotics as well, but with a non-infective COPD exacerbation, you would usually only prescribe steroids. And the old guidelines would be that you would prescribe the steroids for between 7 to 14 days. That was the key guidelines then. And the dose would be 40 milligrams of prednisolone. But the NICE did a literature review and they found that actually prescribing 5 days is sufficient and a lower dose was sufficient. There's no evidence base for prescribing a longer duration of steroids, and there's no evidence base for prescribing a higher dose of steroids. So if you had a PLAB 1 question, for example, a patient has a non-infective exacerbation of COPD, you would treat them with 30 milligrams of prednisolone for 5 days, no more than 5 days. That's very, very important. These are the new guidelines. PLAB 1 will always be based on the new guidelines. Similarly, if you're in a PLAB 2 station and you get an exacerbation of COPD, again, you should only be prescribing or mentioning 5 days of steroids at 30 milligrams, which will be prednisolone. By the way, to get top marks in the PLAB 2 exam, it's important to mention the drug name, the duration, and also the dose. So for example, let's say I'm sitting a PLAB 2 station and a patient comes in and I'm going to manage them for an exacerbation and a non-infective exacerbation of COPD. So what I would say to that patient is I'd say, Mr. Smith, we'll be prescribing 30 milligrams of prednisolone, which is a steroid, for 5 days. Now, these are very small tablets. They are 5 milligram tablets. So you'll have to take 6 of these together, preferably with food, at the same time each day for 5 days. And by doing that in the PLAB 2 exam, you'll get the top marks. Similarly, if you're about to work in the UK as a doctor, so you've passed your PLAB 1 and PLAB 2, and you're looking for jobs or you're about to start a job, an exacerbation of COPD will be 5 days of 30 milligrams. So one of the key things we try to do in this webinar is that we try to give you 3 key learning points for these topics. So I'm going to give you 3 key learning points for COPD. Dr. Sandhu is going to give you 3 key learning points for hypertension. And so you're going to go away with 6 key, very important learning points, which are most likely to come up in any exam scenarios, but also in UK medical practice. So this is the first learning point. Let's move on to the second learning point. And this is the algorithm for how you manage chronic disease management with regards to COPD. And it's important to know this because the guidelines changed in the last 12 months. Previously, the guidelines were based on the FEV1 percentage predicted, and that would tell you where in the algorithm the patient would go down. So for example, they'd go down this route here or this route here, depending on their FEV1 percentage predicted. However, this has all changed now. The algorithm splits into 2, but actually you have to now determine whether or not the patient with COPD has asthma features or steroid responsiveness. So if you want to choose if the patient's going down the left route or the right route, so the blue route or the green route, you need to determine this criteria first. So what does this mean? What does it mean if a COPD patient has features of asthma or steroid responsiveness? Now, I'm going to show you this definition on a different slide. So this is the slide. This is directly from the NICE guidelines. So NICE states that patients with asthmatic features or features suggesting steroid responsiveness in the context of COPD means any one of the 4. The first one is any previous diagnosis of asthma or atopy. So that could be hay fever or it could be eczema, for example. Number 2, if the patient has a higher blood eosinophil count than usual. Again, that's related to asthma-like, an asthma-like picture. The third thing is substantial variation in the FEV1 over time. Again, this is an asthma-like picture. And the fourth thing is substantial diurnal variation in the peak expiratory flow. So that basically means, for example, a patient might have a very big difference in the peak flow compared to the day, to the daytime and the evening time. And again, that's an asthma-like picture. Now, why have NICE done this? Why have NICE broken down the algorithm into asthma-like features or non-asthma-like features? And the reason for that is because there is an overlap between COPD and asthma. And sometimes you'll make a diagnosis of COPD based on the FEV1 over FVC, but the patient's got some asthma features. So the evidence is that if a patient's got some asthma features, which I've shown you here, then they should go down a different treatment algorithm route, which is going to be more effective for that patient. So that's very, very important to know. So in your mind, you see a COPD patient, you should be thinking, do they have asthmatic features or features to suggest steroid responsiveness? Now, one very important thing to keep in mind is when NICE say steroid responsiveness, that does not mean that if you give them prednisolone or steroids, they get better. That's not what they mean. What they mean is these four bullet points here. So again, have a quick read. I've gone through them already. So let's go back to the algorithm. This is the COPD algorithm. Step 1 is relatively straightforward. All patients with COPD should be started on a short-acting beta agonist. In the UK, this will be a salbutamol inhaler. In the UK, it's a blue inhaler. So that's the first step. And they could use it as and when required, or 1 to 2 puffs up to 4 times a day. Now, step 2 would depend, of course, on whether or not the patient has asthma or steroid responsiveness features. If they do, and again, I'm going to show you this slide so you know what we're talking about. If they do have these features, then step 2 would be to add on a LABA, a long-acting beta agonist, and a inhaled corticosteroid inhaler. So it'll be essentially triple therapy, a SABA, a LABA, and an ICS. If, however, the patient does not have features of asthma, again, I'm going to show you the slide. So these are the asthma features according to NICE or steroid responsiveness. If the patient does not have these features, then you would start a LABA, a long-acting beta agonist, but also a LAMA, a long-acting muscarinic antagonist, at the same time as a short-acting beta agonist. So it's triple therapy, but it's the green step the algorithm. So very important to know that those two key differentials in the algorithm. Finally, if a patient isn't well controlled at step 2, then the nice thing about the NICE guidelines is that that wasn't intentional. The nice things about the NICE guidelines is that step 3 is the same for both sides of the algorithm. So the patient will be on a LABA, a LAMA, and an ICS, basically triple therapy in addition to a short-acting beta agonist. So just to recap for everyone's reference, step 1, COPD management, short-acting beta agonist. Step 2 is determined by whether or not the patient has asthma or steroid responsiveness. If they do have those features, then it's a LABA and an ICS added to step 1. If they do not have those features, it's a LABA and a LAMA added to step 1. Finally, if the patient isn't well controlled after 2 to 3 months of step 2, you move them on to step 3, and that's a LABA and a LAMA and an ICS combined triple therapy, as well as a short-acting beta agonist. So those are the 3 key learning points. Just going to go through them once more. Steroids for exacerbations are only for 5 days at 30 milligrams for prednisolone. The algorithm has now changed to incorporate asthma and steroid responsiveness features. And finally, of course, step 1, step 2, and step 3 in the ladder, which we've just gone through. So what we're going to do now is we are going to take any questions for COPD, any questions you may have on this topic. If you can try and make them specific, if that's okay, for COPD, because obviously Dr. Sandhu is going to be doing hypertension in about 5 to 10 minutes. So whilst you guys are thinking of questions, we are going to address them. We're going to very quickly screen share and show you some of the products that we have available with regards to PLAB 1 and PLAB 2. So I'm just going to screen share for everyone's reference. If you just give me a moment. So just to make you aware, we have a PLAB 2 online academy, and we also have a PLAB 1 online mock exam. And these are going to be held monthly. And I'm just going to screen share with everyone before we come on to the COPD questions. So, okay, so Vikas, just give me a thumbs up if you can see my screen. Okay, good. So, of course, this is our website. This is the homepage. Okay, so the PLAB 2 Academy. We have a 10-day online PLAB 2 Academy. It's priced very competitively at $149.99. It'll be done every day between 10 a.m. to 1 p.m. UK GMT time. And there's a selection of dates depending on when your exam is. Now, we are going to give you a special discount for this. Can you very quickly put your hands up if you are interested in the PLAB 2 Live Online Academy? Because if you are, depending on the number of people who are interested, we can offer a higher discount. So just raise your hands. So there are 6 hands that have been raised, 7 hands, 9 hands, 10 hands, 11, 15 hands. Guys, the higher the number, the bigger the discount. So at the moment, we can offer you a £25 discount on that. If the number of participants goes above 25, what we'll do is we'll offer you a £50 discount. So if you're interested in doing the PLAB 2 Live Online Academy, we can actually offer you a £25 discount. However, if more than 25 hands go up, we'll actually give you a £50 discount, which means it's only $99.99 for a 10-day live online academy. Okay, we're at 23. We're at 23 right now. 2 more participants, and we'll actually offer you a £50 discount off this academy. So we're still at 22. Okay, we'll give it another 10-15 minutes to see if any more people raise their hand. The second product we have is our PLAB 1 mock exam. So I'm just gonna try and get access to that. Okay, so this is our virtual Zoom PLAB 1 mock exam. So this is a 6-hour PLAB 1 mock. We'll do 180 questions for this. It's only $29.99, and if you stay till the end of the webinar, we'll actually give you a £5 discount code for this. There are 2 dates so far. We have August, and we also have an October date. It's held between 10 a.m. and 5:30 p.m. UK GMT time. and we'll go through 180 questions, which you can answer live. And then we'll go through the answers for those questions along with the latest UK guidelines, so you can understand what the correct answers are. Again, it'll be live, so you can ask questions during that mock exam at the end, and there's a 1 hour break in between, so you can go for lunch and you can come back nice and refreshed. So that's a virtual Zoom 1 PLAB mock. Very quickly, I'm just going to bounce back to the questions. I think we've got a couple of questions. This is going to lower everyone's hands. We will still offer that £50 discount if more than 25 people put their hands up later on now. Okay, so we have some questions here. Vijas, if you don't mind, Sital has asked the first question.
Maniza has asked the first one. So asthma and COPD stations can be so long. So which things are most important to cover in this station when you talk about the management for PLAB 2?
Okay, so the most important thing to cover if it's a management station is you probably want to take a very brief history, or you may already be given the history. But the important thing in the management is then to talk about, obviously, smoking cessation, drug treatment, which will be prednisolone or antibiotics. You want to review the patient within probably 5 to 7 days. You want to address other risk factors which might be exacerbating their symptoms. For example, maybe the patient's more prone to bronchitis because they're a smoker. So again, smoking cessation will play a part in that. If the patient's oxygen saturations are dropping, they may need admission to hospital. So you need to keep that in mind. So the things you need to think about is does this patient need to go to hospital? If so, you need to manage the patient on that. So it would be, Mr. Smith, your oxygen saturations are below 80% on room air. Your heart rate is 120, your respiratory rate is 25. You have a severe exacerbation of COPD, and this will be best managed in a hospital setting, because if it deteriorates, it could be potentially life-threatening. However, if you can manage it in the community, then you want to talk about steroids, antibiotics, smoking cessation, follow-up, and also you would possibly even get the patient to possibly review the patient in 24 to 48 hours to see if they're showing a response to treatment. So those are the types of approach you should be having depending on the case that you have. But in management, obviously focus on the management and always remember to safety net. So if the patient's having worsening shortness of breath, worsening symptoms, they should seek medical advice. So that's that question. We have another question here from Sital. Are there any changes to the management of infective exacerbation of COPD? Sital, yes, there are changes to the management of infective exacerbation of COPD. Essentially, the antibiotics are now only given for 5 days. Previously, you would prescribe antibiotics for 7 days, possibly more, but only for 5 days. And that's quite nice. Steroids for 5 days, antibiotic 5 days. So that's the changes that in the new guidelines. This is a question from Anonymous. Just to confirm, for step 3, is it triple therapy, i.e. Therapy plus SABA, or is it this triple therapy? So the answer to that question is, if you're at step 3, it's triple therapy as well as a short-acting beta agonist, which essentially means it's quadruple therapy. So just to clarify, step 3 in the ladder is quadruple therapy, which is, I'll just bring it up once more. I'll do a quick screen share. Okay, so triple therapy is LABA, LAMA, ICS, and a short-acting beta agonist. So essentially, it's quadruple therapy to answer that question. Okay, let's go on to the next question. We have, will you offer influenza and pneumococcal vaccine as part of management, especially to those over the age of 65? Chibuki, apologies if I haven't pronounced it correctly. Thumbs up if I have. The short answer is yes. COPD is a chronic disease. You should offer a one-off pneumococcal vaccination, but also a yearly influenza vaccination. Very important in the United Kingdom. And also that be a part of your management if you're managing a patient like this in PLAB 2, which I forgot to mention, which is obviously steroids, antibiotics, smoking cessation, pneumococcal vaccination one-off, and also a yearly influenza vaccination. Very good question. This is from Amir. Hi guys, Dr. Amir here. Thanks for this. For us, due to sitting PLAB 1 soon, what are your thoughts on a whole new set of potential questions on COVID-19 virus? Are there any standardized protocols or guidelines? Amir, very good question. Essentially, for the PLAB 1 exam, you should get almost 0 questions based on COVID-19. And the reason for this is because the guidelines are changing all the time, almost on a weekly basis or a monthly basis. COVID-19 guidelines are changing in the UK. Therefore, they cannot possibly set an exam question based on COVID-19 because there's nothing that's properly fixed. So I wouldn't worry excessively about those types of questions. However, if you are reading the NICE guidelines, make sure you have a bit of read about the COVID-19 section in chronic disease management, just to be aware of it, but it's very, very unlikely that will come in the exam. So guys, don't worry about it too much. So that's that. Anonymous question, what's a LAMA? A LAMA is a long-acting muscarinic antagonist. Vikas, can you give an example of that? If you put your microphone on.
Yeah, so something like a tiotropium, which is the the classic inhaler that we give patients with COPD. So that's a classic long-acting muscarinic antagonist.
Okay. Next question is this is from Charles. What determines whether you go to step 2 or step 3? It's really easy, actually. If the patient's not well controlled on any step in the algorithm and you feel treatment hasn't worked for between, let's say, 12 to 16, between 8 to 12 weeks, they move on to the next step. So basically, poorly controlled symptoms for a duration of time of up to about 12 weeks, you would move them on to the next step in the ladder. From step 2 to step 3, it's usually about 12 weeks. Step 1 to step 2, you can do quite quickly within a few weeks if you need to. Amir says, thank you very much. You're very welcome. Let's see here. Okay, this is from Anonymous. This will be the last question, by the way, before we move on to the next topic. Do you think PPE donning and doffing will be examined in PLAB 2? Any idea on specific ones we can focus on? So the short answer is I think the GMC will be very clear if you are required to wear PPE. The short answer is the answer's probably no. My understanding is the GMC will be providing masks. So you can wear masks if you want to, but I think they'll probably be optional. Again, the guidelines are changing on a weekly basis. It may be that by the time you get to your exam, you don't need to wear any PPE, but the GMC will be very, very clear if you do or do not need to wear it, or if it's optional. So just check on the GMC website. Also check the latest emails that they send to you and drop them an email if you're unsure, but they will be very clear on whether or not you need to wear it or if it's optional. So I hope that answers the question. Final question very quickly from Sital. Should we add ipratropium to SABA for exacerbations? So ipratropium is a long-acting muscarinic antagonist. You can, let's see, add a LAMA to step 2, but only if they have no asthma features or steroid responsiveness. So you can add a LAMA for exacerbations, but remember it's in combination with a LABA. So a LABA and a LAMA together. So ipratropium obviously is a LAMA.
Yeah.
Okay, so we're going to stop it there. I know we've got...
There's just a few other bits. I'm just going to check. So just to make sure. So Deepak asked a good question, which he said there's quite a few questions in which we've got the British Thoracic Society guidance and we've got the NICE guidance, and they seem to contradict each other. So which one should we follow in our exams, basically? The short answer to that really is that the most important one is the NICE guidance. And you're right, there is some contradiction. This has always been an issue throughout our career with any exams that we've done in the UK. But generally they say you should go with the NICE guidance because that's the one that's updated in terms of the national guidance that we follow. And the BTS guidance is a good marker, but if you had a choice between the two, always go with the NICE guidance first. I think that would be fair, wouldn't it? Mo? You wouldn't add anything to that? Or...
Yeah, so essentially you'd always follow the NICE guidelines. That's the main guidelines we follow here in the UK. So guys, I know you've still got some questions. We will be answering a lot of these similar questions in the PLAB 1 mock. Hands up, who's interested in the PLAB 1 mock? It's only £29. Of course, we can offer a £5 discount. Hands up. PLAB 1 mock. This is PLAB 1 mock. If you're interested in attending at some point in the next couple of months. Okay, 5 people. 6, 7. Oh, we're going up. So if you're interested in the PLAB 1 mock, just raise your hand, please. It's only £29.99, £30. It's a full day, 180 questions. And also, of course, at the end, we go through all the questions with the latest UK guidelines. Okay, good. And this once more, who's interested in the PLAB 2 Academy, 10-day online academy? Remember, if we get past 25, we'll offer a £50 discount, a £50 discount to everyone, which is only valid for today. We had about 22 before. If you just want to raise your hand, this is the PLAB 2 Online Academy. It's £149.99. We'll offer £50 off if we get past 25 attendees today. We've got to 15, 17. We're on 17 attendees. We only need another 7. Oh, we only need another 5, and we can offer the £50 discount at the end of this webinar. 21. This is the PLAB 2 Online Academy, 10 days, 3 hours each day, very flexible, so you can obviously fit it into your schedule. We're getting to about 22, so we need about 4 more people if you want the £50 discount. Otherwise, it'll be this £25 discount at the end of this session. Okay, good. Guys, we'll move on to hypertension. VCAS, over to you.
Yeah, so just to clarify, there are some questions that came into the webinar chat as well. And what we will do you want to troubleshoot them now, or should we do them at the end? You need to unmute your mic.
What it is, we're at the halfway point. We may have to answer those questions later if we've got time.
Fine. Okay, fair enough. So maybe 5-10 minutes at the end, and we'll just do a troubleshooting session. So good. So hope that was useful, guys. So the second topic that we're going to cover, and this has just been updated by the NICE guidance in the UK. So I'm going to start to share my screen with you all, and you will get to see what's going on here. So basically, this is the brand new NICE guidance on hypertension. So the reason we've updated these two guidance, the COPD and hypertension, are two very, very hot topics. These are things that you'll almost certainly get a PLAB 1 question on either of these topics, and there's a good chance that you'll get a PLAB 2 station on one of these two topics. And these guidance have only just changed, so many of the resources that people are using may be out of date, and they may be with the old guidance, and therefore you may answer these things incorrectly. So you know, we tend to review the guidance regularly, and when they update, you know, we will obviously inform you guys so that you're up to date as well. So in terms of hypertension, we want to talk about what's basically changed so that you're up to date with your exams and you're ready for your PLAB 1, or whether it's a PLAB 2 station that you get. So the first thing that's changed, and this is very important, is severe hypertension. So severe hypertension is a classic PLAB 1 question. It's also a classic PLAB 2 station type scenario where you may have to manage somebody who's coming in with a very, very high blood pressure. It's also something that we see quite regularly in our clinical practice. Both me and Dr. Mo are practicing GPs in the UK. So the first thing is that the severe hypertension, initially it used to be classed as a blood pressure of equal to or greater than 180 over 110. This has now changed to this here. So it's now a patient who presents with a blood pressure that is equal to or greater than 180 over 120. What we decide to do next depends on whether the patient's got symptoms or not. So the NICE guidance says you would have to admit this patient to the acute medical team on the same day if they've got features of the following. The first thing is accelerated hypertension. And I've included the fundoscopy images, and I'm going to show you them in a minute. But essentially, this is a patient who's got severe hypertension with a fundoscopy that shows evidence of papilloedema and retinal hemorrhages. This is something which they, in a PLAB 2 station, what will happen is you obviously you won't see this in a real patient. Normally, the examiner will give you a card, which I'm going to show you in the next slide. It will give you a card, and they will say, okay, here's the examination findings, and your job will be able to put it together and think, okay, well, the patient's got this severe hypertension, the examiner has showed me this fundoscopy, he's also got a headache, this sounds like severe hypertension, this needs admission, and that would be the focus of your management station. The second criteria, so if the patient has severe hypertension, i.e. a blood pressure which is equal to or greater than 180 over 120, and we suspect a pheochromocytoma, and that is a patient who has, for example, the features that you get of excess adrenaline in the body, so things like severe headaches, severe chest pain, palpitations, so they might complain that their heart is racing. Excess sweating, so is another key feature. Then you would have to admit them on the same day to hospital. The third thing is if they've got severe hypertension and they've got new features of confusion. So normally they may come in to see you with a relative who's complaining that their loved one is more confused than normal, or they've got severe chest pain, or they have heart failure that's exacerbated, so worsening shortness of breath and leg swelling, or indeed they've got history of acute kidney injury. So normally this will be a patient who's already got kidney disease or has recently been discharged from hospital and their blood results recently showed that they had acute kidney injury. Either way, they would get admitted into hospital on the same day. The interesting feature is that if your patient only has the high blood pressure readings but none of the features that we've mentioned, then what we should do on that same day is look for target organ damage. And what that basically means is that we should get an ECG done on the same day. And that ECG will normally, we will be looking for things like left ventricular hypertrophy. So that's when you get the QRS complex, that's very long. You'll also be looking for any ischemic changes on the ECG. You should be doing a urine sample looking for the albumin creatinine ratio, assessing the patient for any renal damage. And of course, there are other things like a blood test as well. Now, the blood test may not come back within 24 to 48 hours, but if your initial ECG is normal and the patient doesn't have any symptoms, then you can watch and wait, start them on home blood pressure monitoring, and review them again within 7 days to see if that blood pressure is coming down or not. This is a change because many doctors will tell you that normally when they see a patient with blood pressure like this, they're normally tempted to start treatment. So this has been a big shift in the current NICE guidance. This image is something, what we say with fundoscopy is none of us are ophthalmologists, so you're not going to be used to examining the eye in the same way that an ophthalmologist would, nor will you have the dilating drops that they use, which opens up the pupil so you can really have a look in the back. So this is, if you're sitting PLAB 1, you may get an image that looks like this with a clinical scenario. For example, Mr. Smith is a 65-year-old male. He's presented into your surgery today with severe headaches. You've checked his blood pressure and it's 185 over 123. His fundoscopy image is shown below, which could be something like this, which shows papilloedema. What would be the most appropriate next step in his management? Select one option only. And you may have several options, such as, start him on an ACE inhibitor, start him on a calcium blocker, review him in 7 days, or indeed admit him to hospital today. And that would be the correct answer. You would admit him to hospital today. And what they're testing you on in the PLAB exam, whether you're doing PLAB 1 or PLAB 2, is how you interpret this picture with the clinical information that they've given you, which makes sense because you're not ophthalmologists and I'm not an ophthalmologist and neither is Dr. Mo. But when you put the pieces of the puzzle together, you'll say, right, okay, this is severe hypertension and we've got evidence of, sort of eye involvement. So if you look at this, this is pattern recognition. So what you see is a very pale optic disc. You can see some of the curvature in the corner here. And you can see all these very prominent dilated blood vessels that are running all the way through. So that's a classic papilloedema. The second fundoscopy change that you get on a severe hypertension case, which you could see as an image in your PLAB 1 exam, or indeed a card that the examiner shows you in your PLAB 2 station, is retinal hemorrhages. So can you see all of these burst blood vessels here that are spilling blood at the back of the eye? And what's happened is that blood pressure has built up so much, your patient has an intense headache, and all of these thin blood vessels here, suddenly the pressure's built up and they burst and they've caused these red hemorrhages here. So almost as if visualize that, save it to your desktop. We will put this webinar in our YouTube channel and also into our PLAB 2 Facebook revision group as well. So you can obviously look back at this again, but it's pattern recognition that you're looking for. Okay, so the next change. So the next thing that's changed is hypertension and cardiovascular disease risk. So we all know that hypertension is a major risk factor for developing ischemic heart disease. And in the UK, like everywhere in the world, there's always a big focus on prevention. So prevention is better than cure. How can we reduce the risk of patients getting problems in the future? So a hot topic at the moment in the UK is when should we start treating a patient with hypertension? Well, if they've got, we have something called a cardiovascular disease risk score that we do in the UK. It's basically based on a number of factors, whether it's lifestyle things like smoking, alcohol, the patient's cholesterol, whether they've got a family history of ischemic heart disease. And after we've taken that information, we can then come up with a risk score. Now that score, normally it used to be if a patient had a score of more than 20%, so a cardiovascular disease risk score of more than 20%, that meant they were at higher risk of ischemic heart disease, and so we would have to start them on treatment. That threshold has now changed. So in the new NICE guidance, they say that if your patient has a cardiovascular disease risk score of equal to or greater than 10%, then you need to start considering starting them on treatment if they have hypertension. Now, what that basically means is that means that we're probably going to be treating a lot more patients than we used to. And it also means that we have to risk stratify each case. So NICE is interesting because they haven't told you that you must do this. They've told you, they've used a specific word. They've used the word consider. And what consider means is that have a think, weigh up the pros and the cons, discuss them with the patients, and based on your outcome, offer them the treatment. That's the key thing to take on board from this slide. The third thing, a hot topic, so hypertension and type 2 diabetes. So many of you will remember this is a classic question. It comes up time and time again in most exams, whether it's a PLAB exam, whether it's the GP exams or medical school exams. It's the blood pressure targets for type 2 diabetics. Some of you may know this, some of you may not remember, but the target for type 2 diabetics, the target blood pressure that we should be aiming for was always lower than the general population. This has now changed. So the blood pressure target for a type 2 diabetic is now exactly the same as the rest of the population, unless, and it's the important thing to remember, just one thing, unless they've got coexisting chronic kidney disease, in which case we should aim to keep their blood pressure less than 130/80. So that's the important take-home message. There's lots of information when you read the NICE guidance, and what we've tried to do is take out the relevant bit so that you can focus your brain power on all of the relevant information, and therefore you're less likely to forget things, whether you're sitting your PLAB exam or indeed you're sitting the PLAB 2 exam. Another important change and an important thing to bear in mind is the concept of postural hypotension. So that is essentially when a patient has a significant blood pressure drop when they move, usually from sit to stand, but sometimes it can happen from lying to sitting. And this is a common complication that we see in hypertension, normally because the patients are older and they will have other medical conditions. And also they have something called polypharmacy, and polypharmacy is something that you should be mindful of. And what that essentially means is that the patient is taking multiple medications for different conditions, and therefore there's an increased risk of those medications interacting and dropping their blood pressure and causing what we call postural hypotension, which is that lightheadedness or dizziness that normally lasts a few seconds. It normally happens from sit to stand, but can also be from lying to sitting. How do you define a postural hypotension? Essentially is if there's a significant difference, a significant drop in the blood pressure, so a more than 20 mmHg drop in the systolic blood pressure on standing, that would indicate hypotension. And the important thing to remember is when you follow these patients up, the next time you check their blood pressure at the subsequent checks, you should always do it with the patient standing up. And that's a significant change because many of us used to see patients and recheck their blood pressure when they sat down. And the big change has come into the step 4 of the hypertension guidance. So we've got a nice diagram which you'll see in the next slide. But essentially when you get to a patient who's had 3 medications, so they're on an ACE inhibitor, normally a calcium channel blocker and a thiazide-like diuretic, and their blood pressure is still not controlled, there's a few things that we have to do. So NICE tells us that 1, check the patient is actually taking the medication. That's what we mean by compliance. Have a look at their home, or what we call the ABPM stands for the ambulatory blood pressure monitor reading. So the ABPM is something that we use in the UK, and I'm sure they do in many of the countries that you guys are joining us from, which essentially is a small monitor. The patient takes it home with them and it records their blood pressure over that week. They bring it back to their GP normally, and then you can see what their blood pressure has been like at different times of the day throughout the last 7 days. And if it's persistently high, we know it's true hypertension. And if it's obviously normal, then we know we don't have to start treatment. Check the patient for postural hypotension, which we've touched on. And then the other thing is the kidney function blood test. So you should always do a UNE blood test at this stage and look at the potassium. If the potassium is less than 4.5, then we start them on the aldosterone receptor antagonist, spironolactone, at a dose of 25 milligrams. And NICE tells us that we should check the U's and E's again within a month. And if they're normal, we can then go back to the normal monitoring, which is normally every 12 months you do a kidney function test on a patient with hypertension, unless of course you change the dose. Remember, spironolactone from your pharmacology is a potassium sparing diuretic. So it's going to cause your potassium levels to go up, which is why you must check that potassium level. If the potassium is more than 4.5, then we can't give them spironolactone because we're going to put the patient at risk of hyperkalemia, and we know that hyperkalemia can be a life-threatening emergency and of course is a cause of cardiac arrest. So what should we do if the potassium is more than 4.5? We now need to decide between an alpha blocker, so a drug like doxazocin, or a beta blocker, so a drug like bisoprolol or atenolol. If we still can't control the blood pressure on 4 drugs, we should refer the patient to the hospital clinic, the hypertension clinic, for further assessment. What this essentially means is that GPs will be managing more hypertension in the community before they eventually refer patients onto the hypertension clinic. This is an important diagram and something that you should be mindful of. And we've adjusted this and we've adapted this from NICE and we've remade it here at iMedics to kind of make it easier for you guys to understand what's going on. So the first thing is age. So if you have a patient who's under the age of 55 and they're not from an Afro-Caribbean background, then the first line treatment is going to be an ACE inhibitor, such as ramipril or lisinopril. And if the patient has side effects, then you go for what we call an ARB, which is the angiotensin receptor blocker, like losartan or candesartan or valsartan. The important thing to remember, though, is if the patient is over 55, you go for a calcium channel blocker, or even if they're aged 55, so aged 55 or over, your first drug that you're going to give is a calcium channel blocker like amlodipine. If the patient is Afro-Caribbean, irrespective of their age, we go for a calcium channel blocker. So again, amlodipine, felodipine, lacanidipine, these are the common ones. So amlodipine is the commonest one that we prescribe in the UK. The other, what we call caveat, the other thing to bear in mind when you're looking at hypertension is someone who's got type 2 diabetes. If your patient has type 2 diabetes, irrespective of their age, we go for an ACE inhibitor first. And there is now evidence, and NICE has recently added this in, there is some evidence that an angiotensin receptor blocker like losartan is preferred over an ACE inhibitor for a type 2 diabetic from the Afro-Caribbean population. I hope that kind of clarifies and makes sense. Then you move on to the second stage. So we've gone through the first stage, we're now into the second stage. If your patient has had an ACE inhibitor and you haven't controlled their blood pressure, you move on to a calcium channel blocker. If your patient's had a calcium channel blocker, you move on to an ACE inhibitor. And if you're still not controlling the blood pressure, you add in a thiazide-like diuretic. Now, these are the newer drugs. So there's things like indapamide and chlortalidone. These are the new common ones that we normally give in the UK. If we still don't control the blood pressure, but we will do that blood test and we will look at the potassium. If it's less than 4.5, we will add in spironolactone. If it's more than 4.5, we will add in an alpha blocker or a beta blocker. If at this stage we still can't control the blood pressure, we will refer them to the hypertension clinic in secondary care for further management. Good. So that takes us to the Q&A section. So I will stop the share. I can see lots of questions are coming up there.
So Vikas, what I'll do is I've just been chatting with everyone in the live chat.
Okay.
There are a couple of questions. Some of them are relatively straightforward. The first question is from Urakpa. Sorry, again, if I haven't pronounced the name correctly. Are there any new, so the question is, Are there any new criteria for malignant hypertension? How does
Yeah.
that compare with severe hypertension? I think you covered it in your first slide.
It's basically the same thing, isn't it? So malignant. So we've got so accelerated hyper. Oh, sorry, I'm trying to log into so accelerated hypertension. The features of accelerated hypertension. If the patient has that, you are basically on the severe hypertension pathway. So they need to go to hospital. So it's that blood pressure of more than 180 over 120, and they'll have clinical features: headache, chest pain, confusion, and they'll have the papillary edema findings of the fundoscopy and the retinal hemorrhages.
Yeah, perfect. I think that answers that. Bahuddin has got a question. We'll come back to that later. Urakpar's got a question. Is the user needs every 12 months or every 1 month? Can you clarify what?
That's a very good question. So basically, when you start spironolactone, you will have to check the potassium, and then you'll check it after a month. If it's stable at that point and there's no significant changes, then NICE has been a bit kind of broad. So they say then you can just go back to routine following. But in general practice in the UK, that normally means every 12 months, we will then check that patient's kidney function, unless their blood pressure goes up and you increase the dose. So for example, if you increase the dose of, say, ramipril or spironolactone, then you should check the kidney function again. And if it remains stable after that month, again, you go back to the routine yearly follow-up.
Okay, good. Next question is from Zeb Unisa. What if the systolic blood pressure difference is less than 20, but somewhere between, let's say, 12 to 14? Do we still call it postural hypertension?
Good question. The answer to that, so that's a good question. If you follow the textbook, then the answer is no. You could say it's mild hypotension and you'd keep an eye on it, but if you're following the NICE guidance, then if the drop isn't more than 20, then it wouldn't be classified as a postural hypertension that you need to act on.
Okay, a quick shout out to Bahuddin. I've sent you a private message in Zoom. You had a very specific question about the recordings. Next question is from Shabina. Shabina says, if a patient has type 2 diabetes mellitus and is Africa-Caribbean, what's the first line?
So what I'll do, I'm going to reload the slide up for you. So I'm going to get my screen back on. It'd be good to show you the visual. Here we are. So I've got it back on here. So basically this will give you, you'll see a copy of this on the YouTube channel, but essentially a type 2 diabetic of any age, the most important thing to remember is it's going to be an ACE inhibitor. It doesn't matter whether they're 55 or 65. And if they're from an Afro-Caribbean background, then NICE says it's better to give them an angiotensin receptor blocker rather than an ACE inhibitor. But of course, it doesn't specifically matter, but it does say that it seems to be that angiotensin receptor blockers are more effective in that population. Under 55, remember, is an ACE inhibitor. Over 55 is a calcium blocker, and over 55 is also, you'd give a calcium blocker for someone someone from the Afro-Caribbean background. But if you're talking about diabetes specifically, you have to go for an ACE inhibitor first.
Vikas, the only thing to add to that is that if they're Afro-Caribbean, then you should probably lean more towards an ARB, an angiotensin receptor blocker.
Yeah.
So to answer your question, Shabina, if they're Afro-Caribbean and type 2 diabetes mellitus, you should lean towards an ARB, an ARB, an angiotensin receptor blocker. And then the second line, where you can choose from a thiazide or a calcium channel blocker in addition to what you've already chosen.
Yeah.
Okay, next question is from Bahuddin. Do you think there's a risk of end organ damage if someone with severe hypertension doesn't have any signs or symptoms of end organ damage and then goes home?
Yeah, so that's a very good question, Bahuddin. Now, this is something which we actually had a chat, me and Dr. Mo were talking about this, because many doctors would feel quite edgy sending a patient home with the blood pressure that's equal to or greater than 180 over 120. Of course, when they've got no symptoms and the ECG and things are normal. What NICE did was NICE actually released a statement on this, and basically what they said was based on the experience of the expert committee members that sat down when these guidance were made. They basically all agreed that people with severe hypertension could be receiving unnecessary treatment because the previous guidelines, so back in 2011, the NICE guidance recommended treatment based on severe hypertension alone. What they all agreed on this time was that if the investigations for target end organ damage could be done quickly enough, and they came back normal and your patient was well, then they unanimously agreed that you can bring them back within 7 days, and then start them on treatment, obviously, if they've still got hypertension. So it was kind of a general expert committee of kind of the guys who developed the hypertension guidance, and they all agreed that the best way to do it was to do it this way, possibly because maybe lots of people ended up on treatment and then they stayed on treatment for the rest of their lives. And all hypertension medications can interfere with kidney function, as we've touched on in some of the slides. So I think what they wanted to do was reduce the number of people who were actually being treated, when actually, if you gave them 7 days, normally their blood pressure would normalize in that time.
Good. The next question is from Sital. How do you calculate, maybe this might be the last 1 or 2 questions. How do you calculate CVD risk? And then there's a second question, which is, please tell us about the target blood pressure for general people and type 2 diabetes without CKD.
Yeah. So basically, the cardiovascular disease risk. So the good thing is, good thing for you guys is you won't have to calculate this in your exam. But what we do in primary care is we have it's a template of questions that we ask the patient. So normally it's, do you smoke? How many cigarettes do you smoke? How long have you smoked for? Obviously we'll record their blood pressure. We will ask about alcohol. So how much do they drink? So you'll probably be aware, but in the UK, male and female guidance for alcohol is only 14 units a week, and that has to be spread throughout the 7 days. You'd also ask about family history. So is there a family history of ischemic heart disease, normally under the age of 60? And the risk is even higher if they tell you that somebody age 40 or 50 onwards has died or suffered with ischemic heart disease. And based on those factors, we then come up with a score. And normally it's placed into a template, and that gives you that score, which may be 10%, it may be 16%, it may be 5%. The lower it is, the better. The higher it is, of course, the higher the risk of cardiovascular disease. Do you want to add anything onto that, Mubin?
Yeah, so Sital, what it is, there's a computer calculator which works out the CVD risk. All you need to do is the height, weight, blood pressure, if they're a smoker, their blood test, lipid profile, and the computer works it out. It's called a Q risk, and it's going to start Q risk 2, and it'll eventually become the Q risk 3 as they kind of make it more efficient. But you don't need to calculate it. You just need to put all the details into a computer, and it calculates it. The second part to your question is that the target blood pressure for general people and type 2 diabetes mellitus is the same, apart from those without kidney disease, of course. So it's the same target. That's the second. That's the answer to your second question. Vikas, what is the target? Do you know the cutoffs?
Yeah. So normally, sorry, I'm just watching you on Facebook, so there's a bit of a lag. I'm just going to just drop out of it because I think there's a we're streaming live, aren't we? To
okay, fine. So yes, so Sital, will this get the answer for you for that? In the meantime, one last question. Zeb says, if the patient has a tickly cough due to ACE inhibitor, can a GP change it to ARB? The answer is yes. So the advice would be to tell the patient stop the ACE inhibitor, and we'll change them to an angiotensin receptor blocker instead. That's correct.
Yeah. Okay. Yeah. Fair enough. So I'm back into Zoom, so I can see you now. So basically, the normal population, you want to aim to keep the blood pressure less than 140/90. If it is a little bit higher than that, we normally then start the patient on home blood pressure monitoring, and we bring them back in 7 days. And if it stays below 140/90, we don't need to start treatment. If it's a little bit higher than that, when they've come back after 7 days, we can start them on treatment based on the algorithm.
So guys, once more, hands up. If you're interested in attending the PLAB2 Online Academy, if we get to 25 people, we'll issue a £50 discount code for everyone. So we've got to 7, 8. Again, hands up. This is the PLAB2 Online Academy. It's going to give it 10, 15 seconds to see where this goes. 18 so far, 18 hands have gone up so far. If we get to 25, we'll offer a £50 discount code to everyone. If not, it'll only be a £25 discount code. If you have friends that are interested who might contribute to that number, please type into the chat box. We'll include those numbers at the same time. 23. All right, we're only 2 away now. 2 away now before we can issue a £50 discount code for the PLAB2 Online Oh, 25. Okay, perfect. We've got to 25. Fantastic. Okay, guys, the discount code, if you want 25, if you want 50 pounds off the PLAB2 Online Academy is, I'm going to type it into the box below. It's 50/50. I'm just going to show you how to use it. So I'm going to do a screen share. So once you've added the PLAB2 Online Academy course to the cart, if you scroll down to the bottom of the page, you'll see a button here for use coupon code. If you type in 50/50, which is the coupon code, it'll apply a £50 discount. So you can see on my screen here that it's applied a £50 discount code, which means it goes under £100. This is a 10-day academy course. There's multiple months available. The discount code finishes in 10 hours. You can only use it in the next 10 hours. We aren't going to offer this discount code again. It's only for people who've attended this webinar, who've taken the time out, obviously, to learn stuff and obviously engage with iMedic. So that's the discount code. It's 50/50. It's £50 off. It's only valid for 10 hours. And then the other thing we'll do is the PLAB1 mock exam will also offer a £5 discount code. So I'm just going to lower everyone's hands for a second. Who's interested in the PLAB1? The PLAB1 mock exam. Hands up. PLAB1 mock exam. Okay, 10 hands so far. Okay, what we'll do for the PLAB, 11 hands. PLAB1 mock exam, what we'll do for the PLAB1 mock exam is a £5 discount code. So it's £29. We'll offer it at £25. The discount code is 52020. I've just typed it into the chat box, 52020 for the PLAB1. That's a £5 discount code. You can use it. It's only valid for the next 10 hours, and then it'll finish. So that's the only time we'll offer these discounts is during these live webinars. So once more, if you're interested in the PLAB2, it's a £50 discount code. Sital is only valid for the next 10 hours. If you want to make a booking, it's 50/50, £50 off, valid for the next 10 hours. PLAB2 Online Academy, 10 days. 30 hours altogether. There's a question about whether or not we'll record the PLAB2 Online Academy, and we'll email everyone later. Me and Vikas, Dr. Sandhu, need to have a chat about this. Henry says, could you please repeat the date and times for the PLAB2 Academies? I'll give you the link, Henry, because there's different, the times are 10 a.m. to 1 p.m. UK GMT time. There's the link where you can have a look at the dates, Henry. You can go through the dates. There's flexible dates available. We do it every month, twice a month. The PLAB2 Online Academy is in twice a month. It's 10 days, Monday to Friday. It's for 3 hours each day, and it'll be 30 hours in total. We'll be going through all the different cases that are likely to come up in the PLAB2 exam. We'll do question and answers. We'll do the latest cases at the same time. It'll be very, very valuable. So again, £50 discount. I'll hardly take up that offer that we've got available during this online live webinar, and it's only for the next 10 hours. So Vikas, what we'll do, is there anything else you want to mention?
So I mean, I think we should just do a quick troubleshoot because we've still got quite a few people on. So a couple of questions. So Sumaya has asked you a question. So what's the difference in the online video course and the live academy that you've described, so the content-wise? I think you need to unmute your...
Oh yeah, okay, so between the academy and the online video course.
Yeah.
Okay, the online video course, basically it's me and Dr. Sandhu consulting with real PLAB actors, demonstrating 100 PLAB stations on how you do them. So for example, their SIMMAN, their history taking, their management, they are basic life support, their OSCE stations, basically procedure stations, and their examination stations. So that's only $19.99 for 1 month subscription. You can watch 100 cases done by me and Vikas Sandhu to get the top marks. You can see how our communication skills are at the same time. The online academy is different. We'll go through all the topics that are likely to come up in the PLAB2 exam, and we'll break them down. So for example, telephone topic, we'll choose it, we'll break it down, what you need to do, what you shouldn't be doing, how you score top marks for data gathering, communication skills and management. And then we'll go through all the different topics. So gynae, skin, acute medicine, SIMMAN, result stations, ethical stations. We'll cover all these in the online PLAB2 Academy, so that on the day of the exam, you're not going to be surprised. You'll know, oh yes, Dr. Mo covered an ethical station to do with prescribing contraception to a 14-year-old who is in a relationship with a teacher. We'll go through all those different scenarios. We'll break them down. We'll take live Q&As, which you can't do on the online video course. You can only do that in the live Zoom online academy. So you can actually ask us questions whilst we're going through those cases, so we can provide you the answers you need for the actual exam. So I hope that answers the question. Vikas, over to you.
Yeah, so basically, just to add really, so the aim of it is going to be, it's going to be split up. So we will focus on, for example, telephone stations. That will be one session. The next session will be acute admissions. The next one will be respiratory. So by the time you've covered it, you should really be comfortable and very confident to actually go on and pass the PLAB 2 exam. What we didn't want to do is cram you, because people sometimes, you know, they turn up for 10 hours and you don't learn anything for 10 hours. What you find is that to get true engagement, you're better off setting yourself 2 to 3 hours a day and utilize, and that's why we've tried to do that into our academy. The second thing is pricing as well. We want to make it cheap so that many of you can actually use it, and obviously use it to your advantage. A couple of other questions and propping up. So I think you should keep an eye on the question and answer box. There's a few things about logistics, about discount codes and stuff. So if you can have a look at that in a moment.
So, yeah, so Zara, the PLAB 2 code is valid for August, September, October, November, and December. The PLAB 2 Academy is online. It's an online course booking, and it's done online via Zoom. Hope that answers the question. If not, let us know. Amir, you missed the PLAB 1 discount code. It's 52020, 52020, 52020. These are for the PLAB 1 live mock, which we're holding in August and October. Same question from Somya has got a question. You also have a communication skills course. Yes, we do have a communication skills course, but we're going to be doing that via Zoom now. It will be available to purchase. If you're interested, just raise your hands and we can do a one-day Zoom communication skills course for the PLAB 2 exam. Me and Dr. Sandu will have a chat. We'll get that live on the website, hopefully in the next few weeks. Okay, we've had about 10 hands go up. Okay, good. Do you email us the notes? This is from Saeed Mad, apologies if I haven't pronounced the name correctly. Do you email us the notes during the academy course? Me and Dr. Sandu will have a chat. At the moment, we're not going to email the notes, because what happens a lot of the times with the PLAB material is that it gets shared everywhere. So often you'll be able to take notes during the actual academy. You can make your own notes, but we'll have a think. We might be able to come up with some summary notes so that it'd be useful for everyone who's on the online PLAB 2 Academy. Somya has also got a question about, this will be the last question, guys, by the way. Somya has also got a question about what the current job market is like for doctors coming in from other countries. Somya, the truth is it's very competitive right now. The demand for healthcare overall has fallen. Patients in the UK are not attending A&E. They're not seeing their GP because they're scared that if they go to A&E or to see their doctor, they may catch COVID-19 in a healthcare setting. So the job market is much more tougher, but the good news is it's getting better, and certainly in the next few weeks, 1 to 2 months, it'll be back to normal, hopefully, as the job demand picks up again. So I wouldn't worry too much long term, and in the short term, it's getting better as well. Asim, thank you for the comment. You guys are doing a great job. You benefited from our video course. Thank you. Everyone do recommend us to your friends and your colleagues. Of course, our prices are cheap because of that, because, you know, we want to make sure that we're value for money. Okay, anything else you want to add?
Just a couple of bits then. So just going to troubleshoot a few bits. So basically, as a gesture of goodwill, anybody who's attended this webinar, you know, we're happy to kind of, you know, support you and give you kind of, you know, the discount code. So don't worry about, some of you said you're waiting for results and things as well. The other thing is, what we try to do is we try to provide you with a support network. So what we don't want to do is sign you up, get you onto our courses and then just leave you on your own. We tend to try and stick with our students. So we've got a very good team here at iMedics. The only thing we ask you is, if you are going to book on, try and book on quickly. And the reason for that is because myself and Dr. Mel are still practicing GPs, and we have to let our surgeries that we work for know in advance that, you know, we won't be available on these dates. Thankfully, there is 2 of us, so normally even if one isn't here, the other one is. So if you are planning on doing something, do book on quickly, so that we, at least if you're going to do it, give us 6 weeks notice, so that we're taking the bookings for August now, because we know PLAB 2 is here. We also know that with all the most courses, well, you won't be doing face-to-face stuff at the moment because of the current guidelines in the UK. So try and book on quickly so that we can then prep our timetable for you guys as well. because then we have to come out of clinic for that. Other couple of things, I'm just going to share my screen very quickly. I just want you to be aware of our material. So there's lots of things that we are doing to support you guys. So you've got the Inspire Medics Instagram page, so Inspire_Medics, which is basically a useful resource. It has lots of relevant material. We do sort of learning cards that people can revise from. It's just simple mnemonics. So if you're preparing for PLAB 1 or you're looking for a refresher for your PLAB 2 exams, then our Instagram page is very good. Lots of simple things. We've got loads of learning cards. Some of our charity work, so you can see us, at the clinic, working in Bangladesh when we did some voluntary doctoring. So, lots of things. Understand a bit about who we are and what we're doing. So definitely have a look at that. The other thing is our YouTube channel. And this is quite a good resource because we're making lots of videos for you guys, which you can use. They're free to use. They're easy to access. The YouTube channel is basically Inspire Medics, and you'll get lots of things like, here's a short video that we put up only a couple of weeks ago about vitamin B12 deficiency. And it has kind of some of the key learning points, microcytic anemia, for example. We highlight some of the key learning points. And the reason for that is because we want you to try and understand and learn, some of the key concepts. But the other thing that you'll notice is that we've kept it short, so that you just get all the relevant information. You can see the key points coming on your screen. This is perfect for PLAB 1. This is perfect for PLAB 2. Because we want to make sure that your revision is efficient. So definitely have a look at our YouTube channel. The other thing, if you're planning on working in the UK, it's always good to keep an eye on our Twitter channel. I don't know if many of you use Twitter or not, but if you go on to Inspire_Medics, you'll get our Twitter channel. It has lots of information about things that are happening in the UK, lots of useful videos, just so that you can keep an eye on things, which is very important for you guys because you want to know kind of, what things are happening. So you're up to date before you move to the UK or travel to the UK. I can see that, this Bassam, you're going to get a shout out. Bassam is a PhD student. He's just followed us right now, which is good to see. The other thing is our, so I'm going to log off this, but this is our basically Inspire Medics homepage. So it's on Facebook. You can basically just type in Inspire Medics, or you can type in @Inspire Medics Home. And again, this gives you a bit of an idea as to what kind of things we're doing at the moment. So charity projects, you can see Dr. Mo in Bangladesh, revision material, information on some of our educational events. Lots of them are free. We've got the link to the PLAB 1 preparation group if you're preparing for PLAB 1. If you're preparing for PLAB 2, then we have the PLAB 2 revision group as well. And we also do lots of stuff for doctors in the UK. So once you get here, once you pass and you're preparing for GP exams and so forth, we have lots of good resources. And our aim, of course, is to make everything cost effective for you guys so that as many of you can benefit from our work as possible. And so that is essentially it. So these are all the social media handles. So do check us out. Instagram, Inspire_Medics, Facebook, Inspire_Medics Home, YouTube, Inspire Medics, Twitter, Inspire_Medics, and we're on LinkedIn as well. So I don't know if many of you use this. It's a professional network, but you can find us on Inspire Medics Limited. I think that's pretty much it. Nothing more to add. I don't know if there's anything else you wanted to add on, Mo.
No, the other thing to add on, guys, is we'll be doing free monthly webinars each month. They're on different topics. So next month's topic is diabetes and migraines. We'll send out a link to all of you if you're interested in registering for that. Don't forget the discount codes for the PLAB 2 Online Academy. It's £50 off only for the next 10 hours. And also PLAB 1, £5 off. That's 5/20/20. We'll see you guys soon. Do stay in touch, of course, and I'm sure there'll be a lot of faces we'll see now, a lot of faces and attendees on the PLAB 2 Online Academy. One quick point is that the PLAB 2 Academy, you can book now, today, get the £50 off, but you can book it later in the year. So September, October, November, December, that's not a problem. There's dates on the links on the website. So take care, everyone, and hopefully we'll see you soon.
All the best, guys. Bye-bye.